All right, we're on.
Hi, everybody, and welcome to SAG 5. I guess I numbered these so I can remember where we've been. But we're happy to have everybody aboard here and we hope you are all warm with power and electricity and safe water and all of those sort of things. We're delighted today to talk about social risk tiering and social risk and tiering and payment model in the ACO model in Minnesota, and I'll introduce Matt in just a little bit. We can go to the next slide. I think we'll just mention a couple opening things. The next full Care Coordination Academy meeting is scheduled for March 10th. And we'll spend a little bit of time talking about CME. I'll turn this back over to our continuing education for all professions. I'll turn this over to Heather in just a couple of minutes to do that. And then I'm going to just spend a little bit of time in the beginning of this talking about where we've been with our SAG topics and where we think we need to go. And that's also an invitation for you all to give us feedback. And then we're going to go into spend really most of the time today with a presentation and then a discussion about how Minnesota put health equity and social determinants into its value-based purchasing. So it's always good to be with all of you. It's nice to see people coming on. And we hope that this is both a discussion via chat and a discussion via when the discussion happens as well. Next slide. Some objectives we have today that we have to talk about. We want folks to be able to identify the steps to identify social risk factors that could be incorporated into a payment model. So to look at how you could do this yourselves, understand the process a state Medicaid program can use to add social risk to medical complexity, and then be able to approach payers about the need to add social risk models to their state and ways to do so. So we're really excited about that. We don't have a slide that says this, but I don't think there's any conflicts of interest for either myself or Matt that need to be disclosed. So Heather, I'm going to turn this over to you now for some of this stuff.
So, thank you, Jeff. So just a couple of housekeeping things. Just a reminder, we'd love to have you rename yourself to include your state abbreviation. If you look at some of these examples, if you go to participant and you find yourself, you can select the option to rename by right-clicking. And then if you put your state abbreviation first and then underscore in your first and last name, just so we're able to identify where you all are from. And then just a reminder, the SAG offers continuing education credits to the following professions: social workers, RNs, NPs, MDs, and PAs. The process for this is I will share the attendance sheet through the chat. I will also email it out if you fill out your name and information, including a good email address on there. You'll then be asked to complete the course evaluation at the end of today's session. And then you will be sent another post-activity survey from the Boston Children's CME department with an additional couple of questions for you to answer, and then you'll be able to get your certificate. If you have any issues or any questions, let me know. And our CME department has been taking about 2 to 3 weeks to get that email out to you. As you can imagine, there's lots of Zoom conferences, so just be patient. If you feel like you haven't got it after 2 or 3 weeks, definitely reach out to me and I'll make sure to get that to you. All right, Jeff, back over to you.
Okay. Well, we've been trying to keep up.
Oh, Jeff, your mic is a little off, I think.
Oh.
There you go.
Is that better? Okay, Matt was having trouble hearing me too, so I'll try to speak up. We've been trying to keep up our travel slides, and I thought this one we would go to the home of BU and Boston Children's and look at it's the Green Monster. Is that what this thing is called? Yeah. So the Green Monster is in Fenway Park, and you can see Fenway Park. I don't know what COVID then is, but I could be COVID-19 as well. But we're looking forward to that. Hopefully our numbers will continue to decrease and maybe we'll all meet in person. But anyway, this is our travel slide. And then we'll go to the next slide, please. I wanted to spend just a couple minutes today. We're on SAG 5, and a bunch of us here get together and talk about what we should try to hit on to make this work. And so I wanted to just tell you, review where we've been, and then I'll show you where you thought we should go. And then we'd welcome feedback either via email or in the chat or when you do your CME evaluations about other things that could help. Remember that the Sustainability Affinity Group is one part of this project, and and I think of it as three parts. There's the part that you guys are superb at about making sure the systems work for the children you serve and the youth. The second part is around measurement, and the third part is about sustainability. I think they're all very interconnected, obviously. So in October, we talked about measures to prove value, and we certainly, I think we need to go back to that at some point. In November, we had our talked about Medicaid managed care and the accountable care model with Gil Liu, who was a Medicaid medical director and is now at Nationwide Children's. And then Steve Karras was nice enough to be our guinea pig from our state and talked about the Inc. team work with Medicaid managed care in New Jersey. In December, we talked about North Carolina's integrated care for kids and Duke's pediatric complexity care with Charlene Wong and David Ming. Next. And then last month, we had a panel that talked about tiering with Children's of Orange County, Orlando Health, and the Philadelphia Behavioral Health team, including Karen and Katie, Tamara, and Camilla. So we're really happy about having this stuff. Oop, we're not ready for that yet, but anyhow, and today we're going to talk about social complexity, which I think is the other part of tiering, and I think a lot of us feel is the other part of tiering that has to come into the picture. And we'll talk about how that has happened in Minnesota, and hopefully we'll give everybody some good ideas about how to start it in their states. Next slide. This is a slide we put up on the first SAG, and these are the topics that when you guys did your pre-work about this, you said you wanted to, the pre-launch survey about what you guys needed, and I'd love to hear whether these are still the same things, if you could just, or if there are other things. The first is evidence-based outcomes of value across the system, and I think we've done a little bit of that with measurement. Next is support for real-time information at the clinical sites. And we have not done that yet, and I think we need to. Value-based purchasing strategies, we've done some of. Care planning and complexity tiering is really a lot of what today's about. And then return on investment justification. I think we could certainly visit all of these, but I wanted to make sure that we honor the requests that you guys had. And if there are more, please let us know. And then I'm going to go to the next slide, which is really Fenway Park. And we've been using a baseball analogy along the way here for the last couple of weeks or sessions. And the baseball analogy is really how to get people and programs to get to score runs. And I think the real legitimate thing here is to say we ought to hit a lot of singles. We need to get people to get started and to do the first steps. And sometimes a lot of singles will mean you'll be a better hitter, and sometimes you'll do a double or a triple, but we really want to get people to do our first step, which is really around understanding and incorporating social complexity into their tiering systems. Next slide. I'll remind people that, that for value-based purchasing or for accountable care models, which are kind of, I think of as there's different, there are different distinctions, but I think that these are, I put this up every time because I think that in terms of defining how to get your care coordination paid for, I think that these are the steps that we always have to go back to: defining who's in the population, defining the service you're providing, stratifying patients by complexity, measuring care processes and outcomes, and then determining payments and how to determine the payments. So I keep on bringing this up there because I think this is what I hope everybody thinks about when they think about getting their models to be sustainable. Next. This is a little dense, but Matt and I had the pleasure of working together in Minnesota, and I thought I would try to put Minnesota's healthcare reform on one slide, although that would certainly is an injustice. But I think that I wanted to do this first to honor the fact that in 2003, Minnesota got a Title V medical home grant, which is where I met the good Dr. Antonelli when he came to visit, and I was able to torment him since then. In 2006, we passed our first legislation to pay for care coordination for medically complex patients. And it was about 2 paragraphs long that said we should do this. In 2008, Minnesota had a large effort around healthcare reform that was part of a governor's initiative. And what I'd say simply is Minnesota decided they wanted to try to improve the system before expanded coverage, because it was done under, I guess, a Republican administration that felt that was important, and did a number of things that included medical healthcare home, as it was named then in Minnesota, and the quality reporting and SQUIRMS, which was the affectionate name for the state quality reporting and measurement system. We, in this 2008, developed our first medical home program. We had a part of the legislation that said that managed care had to pay for it, and had to pay for it in a manner consistent with fee-for-service Medicaid. And I have to tell you that manner consistent with was very loosely interpreted, but we did some complexity tiering. And then in 2010, the first ACO model, which was later named the Integrated Health Partnership, which has been Matt's work, was passed, and then it started to roll forward and has been put into place since then. A couple things to emphasize, I think, that are important is health plans in their contracts pass shared savings through to providers and don't reinterpret how that pass-through happens. It's cost neutral or better to Medicaid. Data is rapidly reported back to providers, and it had a lot of improvements through funding through the state innovation model, which was a federal funding model that came out back about a decade ago. This has been refined a lot. Matt has been in charge of this model and the advanced payment models at Medicaid, and has had both an eye on equity, an eye on social determinants, an eye on fairness, and an ability to talk to providers and communities and payers and internally in DHS with a lot of skill. And we contacted him and had a call, and I was delighted to reconnect with him, and I'm delighted to turn the microphone over to you, Matt, and I'm looking forward to hearing what you have to say about how Minnesota has moved this model forward.
Yeah, thank you, Dr. Schiff. I'm assuming, and maybe just give me a thumbs up, I have had a little bit of technical challenges this morning, or this afternoon. It's already almost 3 most people's time, 2:15 here. So hopefully you can hear me.
Yep.
Oh no. Well, now you guys are frozen. Can anyone hear me?
Yes. Matt,
We can hear you, Matt.
Oh, okay.
I'm hearing you, but you're breaking up. I wonder if you got a bandwidth issue. What?
Yeah, hold on one
Or
second.
maybe it's everybody. If everybody else shuts off video and Matt, you leave yours. Let's see if it's across the rest of the platform. So if you're not speaking, please go on that. And Matt, try that.
Yeah, and I'm gonna also see if I closing a few things. Okay. I'm gonna try one more thing because the sound is now back to being. Oh, hello. So this is super fun, isn't it?
We can hear you okay.
We are hearing
Can
you.
you guys hear me now?
Yes,
Yeah.
we're hearing you now.
Okay. Okay, good. I'll try to muddle through then on my end. It sounds I'm having more problems hearing you guys than the other way, so that's probably fine. Yay, technology. So, but thank you, Dr. Schiff, for your introduction and what I am hoping to be able to talk with you all today about, and we'll certainly leave a lot of time for questions and all of those pieces, is as Dr. Schiff mentioned, the Integrated Health Partnership Program. And as Jeff had mentioned, that we've been around for a handful of years now, almost 8 years, I think, in implementation. I know about 11 years if you include some of the planning pieces. And so we have quite a few what I would call sort of lessons learned, but also, what I think I really want to make sure is well understood today is just kind of the arc of development that we are going through still and have had to go through. And so if you're a state or a group that's trying to look at, how do we approach accountable care? How do we approach value-based purchasing? I think, again, looking at it as sort of the arc as opposed to instantly it's up and running and everything's great. So with that, as Jeff mentioned, in the Integrated Health Partnership Program, it is one where we directly contract with the providers themselves. We started out with about 6 in 2013 provider groups that we were contracting directly with, and we're up to about 27 today, which is a lot. And the reason it's a direct contract is so that it can cut across both the managed care and the fee-for-service populations in our Medicaid population. So it's a pretty wide-ranging population that gets included. We have some exclusions a little bit here and there, but for the most part, it includes most Medicaid folks. As opposed to a lot of models where they may be focused just on fee-for-service if they're the state and allow the managed care entities to kind of create their own arrangements, we went with the direct contracting and kind of overseeing from more of a centralized standpoint. And the point of it really is to incent and support more effective and more efficient care for the beneficiaries. So that's always really been our sort of focus within this program. Initially, and this is sort of the version of the model that started in 2013, we focused on that total cost of care, as well as an array of core quality and utilization metrics, optimal diabetes care, vascular care. We were looking at a number of different sort of disease categories, preventative categories that we were tying quality and utilization metrics directly to. The main incentive really was for that shared savings, for the potential for the participating providers to more effectively manage and coordinate the care, see some savings from reduction in admissions, ED visits, more efficient and effective prescribing patterns, that type of thing, created a revenue opportunity of being able to share some of those savings with us. We also started to implement shared loss or potential loss beginning pretty early. The first loss was actually first loss potential was in 2014. Fortunately, we actually have not had any of our IHPs have to pay back any money through a loss like that. But a big key part of that of our program, even from the very early stages, was supporting the IHPs themselves, the providers themselves, with robust data and reporting that we would create for them. Because again, one of the really fun things about the direct contracting and cutting across managed care and fee-for-service is we had the encounter data, claims data in-house to be able to sort of package that and distribute that to the IHPs as one, as opposed to them getting individual files, sets, et cetera, from multiple different payers. Since we started in 2013, we've seen some pretty significant evolution. The biggest, probably most kind of categorical shift for us, if you will, happened in 2018, which is when we kind of looked at the model and changed it so that it could expand to a wider variety of providers. We'd be able to integrate social determinants of health and looking at population characteristics within the interventions, and then also trying to encourage more meaningful partnerships between the health system and community organizations that are in their area, in their neighborhood. And so some specifics that we implemented in that 2018 model that wasn't part of the 2013 was the creation of what we call a population-based payment. And this is a quarterly PMPM. It's what I like to describe as it's relatively modest, but again, at the population level, it can be really useful in a good set of dollars, kind of like a partial capitation. So it ends up being about 1% of the total cost of care, or somewhere between $4.50 and $5 for each IHP. A big key part of that was that it was modified by both social risk and social risk factors, and I'll talk a lot more about what that looks like and how we sort of approach that. But also by medical risk. And then it was directly tied to health equity interventions, which was something new that we implemented in 2018, where basically we asked the IHPs, look at your population that you serve, look at your community needs, your community health needs assessments, demographic information, really any resource that you have to look at, and pitch us on an intervention that sort of expands care and health outside of the clinic walls. We'll work with you. We'll kind of go a little bit back and forth, but really they were the entity that developed the intervention, and we sort of took more of just the encouragement and how do we support this approach. We also created multiple tracks, as I mentioned, sort of a wider variety of providers. So we have, one track where there's sort of full risk bearing. There's potential shared savings, potential shared losses. But then there's another track which allows for more of your smaller independent practices, for maybe principal care providers that aren't necessarily primary care, meaning that they're the main provider for their population, but they aren't your traditional primary care provider. And then we also tied to those risk-bearing contracts the development of what we call accountable care partners. And this is sort of an opportunity for those entities that have some risk to mitigate that, to have better upside than downside, by partnering in a more formal way with community-based organizations that are serving the same clientele, serving their neighbors, serving their community. And all of this, again, as I said, is sort of the main arc that I want to impart. Is it took time for us to develop and get to the point where we're at right now with the program, and we're also know that we're not done, that there's still a ton more work. But early on, one of the big things that we had to kind of think through, and what I think has pushed to each step of the way what our thinking is, what the development is of this program, is what's the value proposition, both to the state and to the providers, and ultimately the beneficiaries. Initially, obviously, it's sort of that increasing accountability for the states. We wanted to figure out different levers that we could directly create an accountability at the provider level on cost, quality of care that's delivered to our beneficiaries, outcomes for our patients, as opposed to just the fee for service. You deliver a service, we pay you, yada, 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 where you don't necessarily have great outcomes. There's sort of perverse incentives. So that was the value position for us. For the providers, though, it allowed for things like enhanced data. And as I mentioned, we have quite a bit of that. More opportunity for revenue for things. Basically, if you're caring better, you have better chance for revenue that can then backfill some of the kind of services and items that are needed that maybe aren't directly billable through Medicaid. And it created sort of a feedback loop. So it created an opportunity for the providers to be able to have more and deeper conversations with us. So let me kind of talk a little bit about each of those fairly quickly. So in the data and reports, we provide to the IHPs, as I kind of mentioned, one of our big roles is that we collect and counter data and claims data from our managed care organizations. And in Minnesota, we have 8 of those across our multiple Medicaid enrollment types, if you will, or contracts. So we collect that, we kind of pull that together into a single dashboard, or if it's for certain reports or just format, and then send that out to the IHP so that they now have comprehensive data on their patients in a way that they didn't have previously. They kind of can see the care not only that they delivered, but also the care that's being delivered outside of their own system. And that was sort of a game changer. So I think a lot of the initial 6 kind of made a really strong argument and helped us grow to the 27 we have now by telling peers and other systems, hey, this has allowed us to do X, Y, and Z, to be able to get a better understanding of the needs of our population and specific information on specific patients. It also, one of the things that it helped us do is to identify additional or further blind spots where we could look at things like real-time alerts on admits and discharges, other things. But again, it took that sort of initial, let's pull this together and see how we can utilize this as a state and then with the providers to really guide the care that they're delivering. As I mentioned, the direct contracting, one of the big things, and this is one of the value propositions that I think the IHP providers come to us with, are that by contracting directly with us in one of these ACO types of arrangements, they don't have to have multiple different contracts, 8 different contracts in some cases with those MCOs. They can really just go through one and there's a centralized administration. So that became a stronger, again, a sort of a value proposition that they could bring and say, this is something we want to participate in this program more readily, and let's expand through this program. And then, as I mentioned, the deeper partnerships. The kinds of conversations that we've been able to have with those systems that are participating in the IHP program is just night and day over what we probably previously could have had conversations with. In some ways, there was a lot of trust building in the first few years, and that was huge and can't be discounted how important that was. We had to take a little bit of time with submitting reports on a consistent basis that were solid, they were sound, they were accurate, listening to the IHPs when they had a challenge with a particular piece of the program, or with this report doesn't quite get at what we're looking for, or you know what would be useful if we could get to XYZ information, and us delivering on that. And then we actually grew more trusting, I think, of the providers in that they were opening up some of their practices to us, again, in a way that we weren't able to before. Go do site visits and have them kind of talk more about their delivery in a much more straightforward and kind of nuts and bolts way than I think we typically would find ourselves having those conversations with them on. And that, I think, was one of the big keys in taking that sort of slow build approach. As I mentioned, and I just kind of said the slow build approach, we did not get there overnight. As Dr. Schiff mentioned, there were quite a few reforms that we were kind of standing on the shoulders of previously, like healthcare homes, and their focus on care management enhancements and some of the structural pieces that need to be in place. That's huge and been really big. SQUIRMS, which is, of course, one of my favorite acronyms of all time, but the Statewide Quality Reporting and Measurement System. This really allowed for consistent data quality metrics to be collected. Our encounter data collection by DHS from across the MCOs, as I mentioned a couple of times already. So without those pieces in place, it's harder to kind of take the next steps. And that's kind of really some of the biggest pieces of advice that I typically give to states that are interested in moving in this direction is, what are the assets that you have currently that you can build on that will allow you to sort of get some line of sight on activities if we just tweak things a little bit here or there, able to measure things in a meaningful way and have meaningful measurements, and having some of that community conversation that happens when you have these pieces in place is really big. The other piece that I'll say about the program and what has allowed us to sort of grow and develop has been flexibility, and the fact that we as an agency knew kind of from the beginning we weren't always really the experts or the smartest people in the room. In fact, we were rarely, if ever, the smartest people in the room when it came to what made sense from a healthcare intervention and delivery model. And it was important for us to listen to the IHPs and the providers and provide us with feedback on these metrics aren't really the right ones for our population. Here are the ones we think would make the most sense. And that, again, is a two-way street. So we had to be willing to listen, but the providers had to trust that A, we would listen to them, and B, they could give us good information and good things to go with. So, for example, we've had to modify like pediatric quality metrics quite a bit, since the majority of quality metrics out there are really towards the adult population, making some modifications of what sort of in the total cost of care versus out, and then very much around those health equity interventions and measures. That would not have been possible to get anywhere with if we hadn't been willing to be very flexible with the IHPs, and the IHPs being willing to be flexible with us, frankly. So what I'd like to pivot to now, and after I'm done with all of this, we can open questions. That probably is the easiest, particularly given my audio issues I'm having today. I'd like to just talk a little bit more about that population-based payment and those social risk factors that I mentioned that we sort of integrated into that model. So the population-based payment, again, I kind of mentioned, was a way of us dealing with a couple of the different issues that a total cost of care shared savings model or shared loss model has, which is, at best, you're maybe waiting a couple years before there's access to any shared savings. And so making investments in care management reforms and those types of things is harder. So smaller systems that maybe aren't well capitalized, don't have as many opportunities. And so we said, is there a way for us to have more upfront sort of dollars that doesn't break the bank, if you will? But we know that if there's certain care kind of development changes that are made, that we'll see savings and we'll see better outcomes. So we came up with this population-based payment. And as I mentioned, it's a quarterly payment per member per month. That's about 1% of the total cost of care, somewhere around $4.50, $5 per member per month. But it was specifically, when it was created, it needed to be modified based on social risk and medical risk. And that kind of left us thinking, okay, how do we do this? We looked at sort of what was best practices across the country. Was anybody else doing this? And there wasn't really a whole lot. So we had to kind of think, okay, well, what assets do we have? What information do we have? How could we approach this? And fortunately, so the first couple of things we knew is, one, we do calculate it. We use a risk grouper, the Johns Hopkins ACG risk grouper. But we basically use that to calculate the medical risk of a population. So that allowed us to sort of tier all of the individuals that are attributed to an IHP to one of, it's like 95 different categories. I won't go into too much detail because it's really not that necessary at this level. But in any case, we were able to do that. So it was like, okay, we at least have a medical complexity that allows us to say, what's sort of the expected costs versus actual costs for anyone in this population? Well, that was fine. It was the social risk side that really challenged us. Luckily, there was some work that was actually led by Dr. Schiff and his team. So very big kudos to him in our medical director's office that was looking at correlations between different social determinants and social risk factors, disease burdens, health outcomes, and costs. And so a lot of very multifactorial analysis and all kinds of things went into it. But for our purposes, it was really useful just to see what was identified as having sort of the largest correlation with worse outcomes, more costs, et cetera, that we could then look at and see, is there some way to integrate those factors into our population-based payment? We identified that there were really a handful of very specific ones that kind of popped out through that research. And this includes serious mental illness, chemical dependency, homelessness, prior incarceration, deep poverty, and child protective services for kids. For kids, it's a parent with any one of those, as well as the child protective services. And those all sort of correlated strongly with worse outcomes, higher costs to some extent or another. So when we looked at that and thought, how do we integrate this into the model that we have, and again, using the assets that we have at hand. And so we did a number of different sort of analytic runs that looked at, for each ACG category, if somebody was in that, one of the categories and had severe mental illness, what were their actual versus expected costs if we would just look at the medical complexity expected cost? And if you do that over a large enough population, you start to understand kind of the actual dollar to dollar trend of the difference between actual and expected. And then we looked at combinations of factors, and it ended up being a pretty big analytic process, but it was actually fairly straightforward in some ways, in that it was more kind of just stepwise. We could take each of these, and that allowed us to get an understanding of, if somebody is in this 70th percentile highest risk and they have two of these factors, they're X amount more expensive. So that puts them more equivalent to another sort of category of risk that puts them more at the 85th percentile from an expected cost. So this allowed us to develop that population-based payment in a lot more detail than I think we had thought we could before, frankly. So a couple of things though, like these are based on just correlations, and they're really more of a proxy to evaluate the level of support that an individual within one of those populations with many of those factors needs. So it's really not an exact science, but we felt that it was really very defensible and was a very good start. And I think that's another theme that I highly recommend to other states is don't worry about trying to get things perfect. Figure out what's defensible, figure out what makes sense with the information and the assets and the data that you have, start there, move forward from there. So let me make sure I'm covering some of the other pieces. Oh, the data sources for that. Again, this was a big process of trying to figure out and indexing what do we have at hand, what can we gather to supplement what we have at hand. So for the factors that we looked at, a lot of that data, such as severe mental illness, chemical dependency, those are things that we could get through our claims data. So that was great. Homelessness and deep poverty, those are pieces that we can get through our enrollment files, as well as looking at addresses on file. And so there was some, again, some support on the data from that perspective. And it was basically really easy to connect those data pieces because they already were connected. Things like prior incarceration, we had to work with the Department of Corrections, and there is some, fancy phrase, probabilistic matching, but basically you're trying to guess pretty well who is this that John Smith or not, based on a number of different factors. And then Child Protective Services is information that we can get from another area of the Department of Human Services. So again, it was one of those things where we were just kind of looking out, what can we get at the individual level? What can support the activities that we want to do? We do, so I want to highlight, trying to look at my notes and make sure I'm covering the pieces I wanted to. One of the pieces around that social risk information that we collected for the population-based payment, and then I'll talk through the accountability a little bit because I got a question through the chats here. We do share population level social risk factors and demographic data with our IHPs. One of the things that we found is that that's incredibly helpful to augment their own understanding of their population. Sometimes it can highlight, we've heard things like, we knew that homelessness was an issue with our population. We didn't realize it was quite this big. Or, wow, that SMI is a lot higher than I would have expected it to be. Seeing it this way, that's really useful for us to think through, what do we need to do for that? Another piece, though, is that it's dangerous, we felt, to necessarily tie some of that information to the individual because of, for example, on the prior incarceration, we can maybe be 99% sure that that's individual A is individual A in this file, but we can't be 100% sure. So that was one of those where it could just kind of highlighted that there is some sensitivity in how we share the information and the kind of the directions that we take. So I've mentioned kind of this population-based payment, the social risk factors. The question that came through the chat is how we're defining health equity within this context and what does it mean in practice? And this is a really excellent question. In some ways, I think us talking about the accountability that's tied to this population-based payment as health equity interventions was maybe a little premature. The idea, I think, was that by addressing social determinants and social risk factors, those things that are outside of the clinic, we are affecting the kind of health equity outcomes. But I think that it's quite possibly a little bit of a broad understanding of that term. And so within this, I've come to kind of think of it more as whole person interventions, population specific interventions, but the equity piece is the fact that as we're looking to evaluate what is happening to the different interventions, and we have, like I said, 27 different IHPs, about 32 different interventions across them that address such things as food supports, transportation, identifying depression or other severe mental illness within pediatric or adult populations. Maybe the SMI is just adult populations, but I think you guys get what I mean, et cetera. Some of those pieces that the IHP in many ways kind of can define a lot of what it means in practice with us more learning and kind of gathering information from them through that. So, and we did just get another question that I think I can answer, and then I'll try to finish up and then we'll just open it to more verbal conversation. But on the race and ethnicity in that piece, so we've just started looking at, and this is where I mentioned before about how you start with what you have, you look at the assets that you have in place, and that you don't try to get everything perfect before you start putting something in place. And each of the steps really, I think, builds on prior steps and helps you do more. We have not really comprehensively looked at the impact of race and ethnicity and the disparities that we know exist that are based on race and ethnicity within our quality metrics, our costs, or these sort of social risk factor pieces. We're starting to look at it now. Part of the challenge is that we haven't had great race and ethnicity data historically at Minnesota's Department of Human Services. Generally, it was self-reported, and there's some anecdotes, at least, that even that self-report was not always actually the person self-reporting it, but it might be a case manager looking at the person and reporting it, which, as you can kind of imagine, might have some false info in it then. There have been some attempts, though, to grow the reliability of that data that I think we are still waiting to actually have some to grow to fruition. But currently we do, at least now through our different enrollment systems, we're up to about 75% race and ethnicity identified with reasonably good accuracy, we think, but that still leaves about 25% unknown. So we're starting to look at that and saying, again, it's not 100%, it's not 90% where I would like it, but it's probably enough to start understanding if these factors have different different impacts on their costs and their level of support, maybe even on how many diagnoses we have for person A versus person B based on some of those disparities. So it's definitely, like I mentioned, kind of the next step that we're looking at. So I want to get to my takeaways, and then again, I think we can open it to the larger conversation here. But as I mentioned, a big part of what I think has worked for us within the IHP program is partnerships. Partnerships really are key. And that's the partnership between the providers and the payer in their own community, and looking at the different interventions and how they can grow those. That's where the information is going to come from. That's where sort of the knowledge really comes from, is community groups talking with the providers and them kind of coming to us and saying, this is what we think will work. Let's figure out a way to support this. And I think this has been one of the biggest and most important outcomes of the IHP program, has been enabling those conversations to take place. And sometimes they're very hard. The next thing is that no data are perfect, as I just kind of mentioned across all of these. But in designing these programs and looking at what are our opportunities, good enough can and should be good enough, at least to begin. And so I think it's really important to kind of look at what you have to work with, where your gaps are, and whether those gaps or blind spots can be filled through other data sources, through other partners that might be able to help. The payers themselves, Medicaid, I think we have a real responsibility in playing a strong role in filling those gaps as well as possible, and knowing that is a good investment to put money into that to support. And then also understanding kind of the data limitations. Is the data good enough for population level versus individual care management level? What are some of the ethics and other pieces around that? One of the big pieces we've really landed on is, we're not sure that this information is great for individual purposes, but maybe it really points out that this is something you want to integrate into your intake process of gaining some information and doing some intake assessments that focus on homelessness or housing or food, or depending on what the issue is. The other piece I would say is that measurement does need to have a purpose, and most likely anything you measure can have multiple purposes. That's something that we found, again, in looking at utilization, looking at the clinical quality measures that we have, that we want to look at those for the purpose of understanding that care is kind of focus on cost. We're not losing quality care. We also want to focus on what can be improved. So then that might be a different type of measure, but it can also be a different just sort of view of the same measure. So again, using multiple measures to try to look at the overall health of the population versus a couple of measures for specific population management or individual care management. And then the last piece, which I think is really the main one that I hope you guys get out of this, is that the best ideas really do come from the front lines. They come from the providers. I think the majority of folks probably on this call are provider positioned. And that's really where those great ideas come from. Please don't assume that the payer knows what will work and what makes the most sense within the communities. The providers are sort of embedded, and we are looking for really good ideas. Pitch us on them. Know that if they serve kind of our collective goal, there's usually some traction that can be made there. So, Dr. Schiff, do you want? We did get one or two more questions through the chat, which I can address, or you tell me how you want to handle the next part of the conversation.
Okay. I'm going to encourage people to either chat or raise their hand. I think it's under the reactions page if you want to talk, or you can just chime in. But first, Matt, thank you for talking about what you've done for the last 5 years or so in 20 minutes. But I really, I think that what we asked Matt to emphasize, and I think he did really well, is to talk about how to get some of these things started and to get to to get to first base on a bunch of these. I want to, I think what we'll do is we'll do the questions in the chat, and then I have a couple sort of things I'd love to discuss with you, and I'll ask anybody else who wants to chime in to see what their questions are. So Matt, the first one is about country of origin data and immigrants. And I know we've had some of that data, but can you talk about where it comes from and, you know, how you use it or?
Yeah, at this, so the country of origin or immigration status does come from our enrollment data, I believe. I'm almost certain of that is actually where we get that. And so it's relatively accurate, we believe. I don't know how large our immigration population is across the IHPs. I can say that it's pretty consistent with the Minnesota immigrant population and the enrollees within Medicaid. It's proportional. We have a very large population of Somali immigrants, Hmong immigrants, a number of other sort of immigrant groups and refugees. And enrollment or at least attribution through our program is pretty consistent with that. What we've done with that information, we did look to see if there was some impact on health outcomes, to see if there was some health, impact on costs, disease prevalence, that type of thing. Generally, immigrant populations look healthier on paper in most of the analysis we did. I don't know that anyone is convinced that that's entirely true, that maybe it's a matter of how we looked at it. Are there some factors that are kind of not coming out because of, perhaps people within a certain immigrant group not feeling comfortable enrolling or not feeling, comfortable with getting care of certain sites. So we actually maybe are lacking some of that information. So when we've looked at this initially, particularly for things like the social risk factor, they didn't really pop out as a factor that we could utilize because, again, they generally looked healthier. Kind of a similar sort of strange result were actually people who are homeless without any other risk factor that we could identify also looked like they were less expensive and healthier. And we're also pretty sure that that's probably not true. What that probably highlights is a lack of getting access to care. Those who have some, if they have chemical dependency or SMI are probably more likely to be engaging with the system than those who don't have that diagnosed. So, so we're doing more to look at to see if there's some disparities that we can kind of highlight that are beyond kind of this sort of initial look. And that includes things like immigrant status, geographic location, zip code, or census tract, some of those pieces to be able to identify if there's some useful information either for us or just to provide to the IHPs to use in a way that makes sense.
Matt, I want to emphasize something that's obvious, and you've said it a lot of times, but that this was it's an iterative process, and in forming the partnerships that you did with the providers, no one expects perfection out of the box. So, and it gets better. I want to emphasize. I want to get to Rahel's question in just a minute because I think it really points to the perspective that most of the people on this call are coming from, which is the provider perspective about this rather than the Medicaid perspective. Let me just say one other thing first, though, because you talked about, and I remember when we got to the 6 issues, the 6 social determinants that we could see made a difference. I think we were pretty excited because we could remember 6. And also, I think I was pretty excited because, not that you want anybody to have these social risk factors, but I think what it really meant to us was that they correlated some, at least for those of us who have done this work or have been involved in reading the work on adverse childhood experiences, and knew that adverse childhood experiences were things that were both economic and, as Justine, who's on my staff, talked about, were about family functioning as well. So you took the economic parts, which were homelessness and deep poverty. You took the family functioning ones, which were serious mental illness, substance use disorder, incarceration, child protective involvement, and you linked the kids to the parents' outcomes. And all of a sudden you had something that was very understandable to the provider level, that everybody knew, but it also made a lot of sense. And so I just want to put a little plug in for something, because I think that Nick talked about this from Philadelphia, and we talked about race and ethnicity. I think about social risk factors as ones that are modifiable, which are the economic and the family functioning ones. You want people to have we want less families to have to be involved in child protection and incarceration, and ones that are not modifiable and that we really actually want to celebrate, which are things like racial and ethnic diversity, GLBTQ status, those sort of things. So I just think that that's important. But I think that I'm bringing this up just because, as people are sort of absorbing what Minnesota did, I don't think it's impossible to think about doing some of the screening around some of these social risk factors and going to your plans or your Medicaid agency and saying, we're starting to screen for these because we know these cost more, and we know that it takes us more time to work with our families around these issues. Can you help us with this, even if we don't have a perfect numerical number around this? So I just wanted to really drive that point home. Let's get back to Rahel, and you can certainly unmute if you want to talk about this too. But I think that your question is really a great one about provider workflow and processes, and how that data, how they use that data and who gets it. I think has been really kind of an interesting thing, because it relies on the systems actually working with their frontline providers as well.
Yeah, and this question is really at the heart of everything we're doing. And it's the question that at moments in developing this program has left me feeling despair, until I found, kind of realized that the information and data and stuff that the stuff, if you will, that we were providing to the IHPs was getting past just the kind of contract manager at the highest level. Because I will say, in the early stages, it was like, well, great, all of our conversations is with the C-suite folks for the most part, maybe a medical, a couple clinical people here and there, but what's happening at the front lines? And so again, I think this question really is the key one. And broadly, I would say it depends. That the changes we've seen at the provider level have been pretty wide. And so there's some groups that are, and part of the reason for that is that we have very large systems, here in Minnesota, Alina and Fairview, they're incredibly large multi-specialty systems with just a ton of locations, several hospitals, et cetera. And their approach is going to be different than a small rural health clinic out in Otter Tail, central Minnesota. And that has played out. And so the reason I say that is part of what we've had to do is not assume sort of one solution for each, or for all the IHPs, and provide multiple different kinds of information. So a number of the social determinant or social risk factor types of information have helped some of the larger systems determine what they might want to look at from screening or intake purposes. And okay, do we focus or change our intake so that we're starting to develop some questions around housing insecurity? that kind of thing. For some of the smaller groups, it helped them say, hey, we're not necessarily doing a great job. It looks like we have a lot more folks with a severe mental illness. And then we also, the data, you know, from our other data, maybe a large portion of them that have a depression diagnosis, but honestly, we're not sure if we're reaching them. So then they go down to their clinical level and identify how are we in, when somebody comes in for a service that's maybe considered more of a physical, or they're in the ED for something, do we use that as an opportunity to then maybe screen them for some of these other conditions? Sort of the main big way that I think we have seen across the IHPs some workflow changes and internal processes is around the care coordination and identification of people with either chronic conditions or sort of maybe not the top tier, but the second and third to the top tier. These are individuals that we maybe need to see, do we have any kind of care coordination activity around them? And that happens then, that information tends to go down into the different care coordination, the nurses, RNs who are doing that kind of a care coordination activity. And again, each system develops that team a little different. And so we never want to be in a position of saying, this is who should get this information. We allow them to do it. But that's typically what we've seen is they'll then literally just have lists of people of, here's who has had this level identified, has this need for care coordination. Can we reach out, see if we can get them in, have a good conversation? One of our HPs that's made up of a number of independent provider practices, for example, looks at our monthly reports. We have what we call a care management file, identifies basically those individuals that are kind of at the highest level of potential complication risk from some of our tools. And he then distributes a list of 10 to 20 people that this week, these are the ones I want you guys to focus on and reach out to and see if, you know, they haven't had care for X amount of time according to our records, et cetera, et cetera. And so it does create kind of on the ground, really specific changes. Some of that tiering I think can be helpful too, one at the executive or a couple levels down, but still kind of in that management to identify what does our population look like? Are we sort of looking at higher risk folks, and maybe that makes changes to some of where we invest. So we've seen some of that as well. I think one really great example, and I wish I didn't have it because it's tied to the pandemic that none of us, or all of us wish didn't happen. But early on, so March, early April, we were looking at our program and, you know, with the pandemic that just came upon us and looking at our data and saying, you know, there's so much information here that could help our providers basically identify who is at highest risk for complications if they get COVID-19. And if you remember back then, we were starting to get more and more information on the different factors, health factors, life factors, those kinds of things. And we were realizing like we had this information for the most part, but maybe in multiple different places. And it was actually stuff we gave to the IHPs. But this is where we saw we had a role of facilitating that data kind of aggregation and reporting, and we put together individual level COVID-19 at risk lists for each and every one of the IHPs so that again they could then reach out, call, and we heard from IHPs across the spectrum, the very large ones to some of the very small ones that used that, and it was just an Excel spreadsheet frankly, and used that very specifically to do outreach calls. I've heard at least one of them is starting to use that, and we give that information to them on a monthly basis now, so it's refreshed regularly. But I think that shows again that there was an asset that could be used to identify people at the individual level, and then they were able to actually change how they reached out to their patients through that and adapted. Hopefully that answers the question.
That's great. Hey, Rahel, feel free to chime in if you want to ask any follow-up questions. Matt, I wanted to ask one follow-up question about that. Can you give some examples of how the IHPs, because this is always a problem in big systems, how the IHPs provide resources to frontline providers, either through centralized or localized care coordination, or, you know, I used to say when we did the medical home that we weren't going to get the docs rich, but we're going to get them home for dinner more often. You know, yeah. So I guess I'm curious as to if you can give some examples of how the IHPs have used their funds, not just in the C-suite, but further down to help frontline providers manage and improve the quality of care for the people they serve?
Probably one of the biggest is just, we have heard, particularly in the larger systems, but even in some of the smaller ones, that in utilizing some of these extra dollars, they've been able to enhance the teams that are at hand for the physicians and the nurses that are maybe working with the patients and the clients on clinical issues. They've been able to hire people, community health workers, or maybe a nurse at a lower certification, that can then take some of that care coordination and that, sit down, let's work through, let's try to navigate your health a little bit and see what your needs are. And that, I think, has been one of the biggest, most significant, consistent things that I think really helps to keep the frontline provider focused on what they're best at in that healthcare, and not having to necessarily search for answers that maybe they're not in the best position. Because, and then tied to this is one of the things that we feared was by encouraging greater screening, better intake, which is another area that we've seen some investment on, is kind of creating uniform intake across multiple organizations, if it's more of one of these collaboratives and that kind of thing, that I think helps out the providers. Is, hey, everybody's really interested in knowing more about these social determinants. What do we do when we find out that somebody is facing homelessness? What do we do if somebody's facing this? And those dollars have actually allowed them to hire people that can focus on that. And like I said, that's large systems we've heard that from, but we even heard it from one of our smallest systems. Literally hired somebody, and they call her their resource person. She just knows stuff, is kind of her job description. So if somebody comes in, she knows where in the greater community, and this is rural, so we're talking about maybe even multiple, many counties away, here's a support that I can help you get connected to. And that, I think, kind of creates an efficiency and an effectiveness that you might not have in lieu of some of this value-based dollars.
Do you want to, I want to move over to the measurement side of things. Rich asked this question, and I think it's one of the things that we spend a lot of time thinking about, is what are the measures that, so an IHP gets paid based on how it does in its risk population. It can get a reward of funds aside from the population-based payment, although that's part of the calculation as well. But you can lose points if your quality measures aren't very good. And I think that's been, I guess what I'd say is, Matt, I think there's a set of IHP measures that are in place, that get put in place for everybody, that are kind of core set-ish, that can be done as an outcome set. But I think there's also a set of process measures that you kind of, I guess, so there are softer measures that you're willing to consider as for special circumstances. And I just wonder if you could talk about what the measures are, probably maybe a little bit about how they're used in the calculation, but more about how you sort of put that all into an equation for the value-based payments that get calculated.
Yeah, it's a good question. It's a good one, because I don't think there's just an answer, and I'm sorry that you brought me on, and I'm here to tell you there's not just one answer. So, which is going to be the answer to this question.
With ambiguity is what we're supposed to be good at, right?
Yeah, it's something you got to get used to. But so we do, on the total cost of care side, we have what we call the core IHP metrics. I think that some providers would probably scoff at at my suggestion that that is a parsimonious set of quality measures. And part of the reason I say that is that, we do try to match CMS's approach in the kind of different categories. So we're looking at some chronic condition categories, preventive care, and screenings, a couple of other outcome measure kind of things. But what we're trying to do really with that set, and this is getting back to my point that I had in my presentation about know why you're measuring things, and know that there's multiple reasons. Depending on your purpose, your approach to measurement is going to change. And that's a tautology, right? Like, obviously. But here's the example. So for our total cost of care, one of the things we're trying to make sure that we guard against is lower healthcare outcomes due to sort of cost saving mechanisms that are maybe misguided or wrong-headed. And so our purpose is really in that case to say what we want to see is a maintenance, maybe an improvement, but at least a maintenance of your metrics across a broader array. What we then do and have done is through the population-based payments, and we're looking at different ways to maybe integrate some of these learnings into the total cost of care. But again, everything's a moving target and everything evolves. In that case, we're looking more at specific measures and metrics that tie to the intervention or the population that we're interested in. So in this case, again, the purpose really dictates what we want to look at. And that also creates a good opportunity for us to maybe get some more robust information. So here's what I mean. For each of our population-based payments, what we call health equity interventions, which again, I think is a broader term, use of that term than I maybe want to defend yet on this call, but we look at utilization metrics that might be tied to that. What sort of would you expect to happen from a utilization standpoint if you're successful with these interventions? Clinical, and then what we call, again, we kind of call it our health equity measures, but it's more, how well is the intervention running? Do you have outcomes? Probably not, but maybe if you do, we'll include those. But from a process standpoint, how well is this going? So on the utilization standpoint, for the most part, what we do end up looking at, and this is negotiated with each individual IHP, but there's only so many, frankly, is things like ED visits, hospital admits, readmissions, length of stay is something that we try to get at too. And those allow us to kind of say, are you seeing some clinical outcomes that maybe impact our cost side? And then I should say, we also look at the clinical. So let's say it's a food security or food insecurity program, something that's focused on trying to eliminate the lack of healthy and nutritious food for people. And we know that they really focused first on people with diabetes, and then they've expanded it to people with other kind of chronic heart conditions and whatnot. So in that case, we might look at some of the clinical measures around diabetes care and outcomes. We'd look at maybe some on if it's, like I said, if they added also some people with heart conditions, we'd look at some clinical measures around there, utilization metrics at their overall population. But if we can get at that narrower group as well to see if there's some change to their population outcomes through that. But then in that sort of health equity metric set, we look at what I kind of call your heads in beds. How many people have been touched by this program? If there's referrals, how many of those referrals were fulfilled? What's the loopback mechanism with those referrals? Did anybody from your office call them to see if they made the appointment and they showed up to the appointment and they got the food? How is that going? Some of those pieces, as well as narrative that allows us some qualitative side of things as well. So again, kind of the reason you can't just sort of grab any number of measures and hope that they kind of work for the purposes you're trying to get to. You kind of have to think, what do we want to measure because this is the intervention or the change that we want to see? Does that make sense?
Yep, absolutely. I think this gets into something that we talk a lot about structure, process, and outcome measures. And you're really saying that structure is, have you done something that's significant, and the process are how many people you've touched, and then moving it further along upstream is important. But I think that just to circle back to some of the detail, which I don't think is I don't want to overemphasize this, but some of the IHP measures go against, I guess I would say in air quotes, the total cost of care reward that a group can get. But I think it's fair to say that most groups that are doing good work bring up their quality and down their cost at the same time, which is always the goal. And then the population-based payment measures are really more of these process things. Matt, I wanted to say one other thing, which I just think is so ultimately cool, is because I think it drives home something that we've talked about on these calls and the Care Coordination Academy has. is that there's an interesting mechanism by, and you mentioned this earlier, but organizations that have accountable care partners get a little extra in one interesting way. Will you just, and it doesn't, I just want to say to everybody on the call, it doesn't have to be in that way, but it's just a sort of a really cool way in which you have acknowledged and supported partnerships of medical facilities with outside community organizations.
Yeah, so this is because we're the state, we like to acronym everything. So this is our Accountable Care Partners, or ACPs, because why not have an acronym for something that's pretty straightforward? So basically our agreement with the IHPs when they have a risk arrangement is develop one of these, an ACP contract or other arrangement that's formalized. And what we will do is we will allow you to have basically the equivalent of 2-to-1 risk, twice the potential for gain as you have for loss. And how we get there, we had a couple of different options basically. And again, it allowed for maximum flexibility. But one of the options is, and this is going to get into a little bit of, I'll try not to make it too technical, but the idea that, you know, within any sort of shared risk arrangements or an ACO arrangement, there's what we call risk corridors. So that's, you know, if we have a target, we say you're going to cost $100 PMPM, obviously a made up number for purposes of this. If you're at $105, that means you're 5% above your target. You've shown losses. If you're 5% below or 95%, that means you had 5% savings that we would look at. Those would be the corridors, 5 and 5. 2-to-1 would say you have the ability to share twice as much of wide of a quarter on the, I should say, on the saving side than you do on the loss side. So you can share up to 10% of savings and only have to have skin in the game for the first 5% of losses, which means if you had a catastrophic year, you're kind of capping your potential loss at a fairly, you know, at a lower amount that you can manage, but you have a potential for even more gain. We've had a couple of IHPs show interest in that. The other option is the one that I think we found the most interesting, and again was the most interesting to the IHPs, because everybody considers themselves, you know, nobody expects that they're going to have losses. Everybody expects they're going to have savings, which is a good way to come into this. So instead we said you'll have 2-to-1 option on sort of what you gain in your savings versus losses. So what I'm talking about there is typically an IHP would have 50%, 50-50 share of losses, 50-50% share of gains. If they have this ACP in place, they can have like 70% share of all the savings from the first dollar up to whatever quarter. And then the matched quarter, they only have to pay back 35% of every loss from the first dollar. And so again, they're really mitigating their losses and maximizing their gains. And we weren't sure what the pickup of that would be. And every single IHP that was eligible for a risk arrangement was like, yeah, we're in on this. Let's figure this out. And, you know, that allowed us to, again, kind of like really push for, hey, we need to see that there's ink on there's basically this arrangement is inked. It's not just sort of what we saw previously was referral networks, which was, you know, equivalent of, well, we have a phone number for this organization, so we can refer people that way. We needed more. We wanted to see contracts in place and in a way that really supported both the organization and the health system. And again, it really attracted, I think, a lot of energy and a focus on how do we formalize, what does that mean? We don't require that the IHP necessarily save any of that additional or share any of that additional revenue, but we did kind of say that there has to be something in place. We'll allow the organization to say what, you know, they think is appropriate within some guidelines, but we sort of push them to, we need to make sure that that partner is sustainable and that sort of the increase in referrals doesn't actually destabilize them, so that you're providing them with support, whether it is revenue or, you know, something else.
Thanks.
And to kind of tie it to one of my main points, that is the kind of conversation I don't think we could have had in 2013, but we were able to have in 2018.
Yeah.
So.
Right. No, I just think it's really, because I think one of the issues that comes up for a lot of communities is how does the community become part of this when there's a big institution that may have a very nice looking building in the community, but is not as much a part of the community as people would like.
Yeah.
I want to go, there's two questions in the chat. One is from Rachel about how is an IHP different from an ACO? And I'll let you do that quick.
Not, I mean, it's not by definition. We started out overtly calling ourselves an accountable care organization. I would say that what the IHP program is now is more of a spectrum of value-based purchasing, with accountable care organizations being kind of one point on that spectrum that the IHP program can accommodate. I could devolve into a much more philosophical discussion, but it's, for practical purposes, the IHP really is an ACO plus, I guess I would call it.
Yeah, and I think that I think one of the things that you said, which I a bunch of times, but I think is really kind of interesting, because I remember when we, when we looked at the legislative language, it's you want to maintain the maximum flexibility for the state, because that gives you the ability to put in more nuanced population-based payments, more nuanced measures around that, without having to go to the legislature or go through a rulemaking process or anything like that. So that's been something that not every state will have the ability, on this call will have the ability to do, but I think that the other important thing, I think, is that it's the state's partnership directly with the providers. The managed care organizations, I guess, I would say, are interested observers here more than active participants, but you may care to comment on that too.
Yeah, I think that there's a lot of learning that we're able to sort of learning for all the payers, including our managed care organizations, that we're able to sort of, because we have that flexibility and we can kind of test and pilot things a little bit more nimbly than we could under a different arrangements. And if there was, either we were too prescriptive or we're trying to manage each of these pieces directly through the MCOs like some other states, we might not have the same ability to kind of have so many different iterations running and have those learnings. So I think that what we're doing is it creates learnings that the MCOs can take away and other commercial payers could take away too. Of course, our population's different than commercial, but
Rhonda from Gillette asked the question that's right related to that, and that's about this discussion at DHS about sharing the IHP methodology with commercial payers, asking as having the robust data available via IHP available for our commercial population would be awesome. So I don't know where that's, I know where that was at, but I'm curious where that's at now.
It would be awesome, and I think we want to push for that as well. That during the SIM, so the State Innovation Model work, which closed up a few years ago, but went for a number of years. 4 years, 3.5, 4 years that we were part of SIM. Gosh, the dates are starting to fade already. But in any case, through that, we facilitated, and by we, I mean more the state through the DHS, Department of Human Services, as well as our Department of Health, facilitated a lot of conversations between payers, which included the commercial and the managed care. And it was a little bit of like, you show us yours, we'll show you ours. And unfortunately, there wasn't as much. There was a lot of us being able to share what we were doing and less coming the other way. And so obviously we don't have direct control or anything over commercial plans. But we did do a lot of that sort of sharing at that point with less outcome, I think, from it than I would have liked to see. But we do still share the information and the model with anyone who asks, including commercial payers. I think we're having more conversations with managed care organizations that do, in most cases, have a commercial side. So, I mean, I think part of our hope is that we'll see some bleed through, but I can also appreciate that on the commercial side, there's, so many conversations and contracts that they have with employers that may be different than the ones we're trying to have and what we're looking at. So I can appreciate that they have different things that they're trying to manage. But yeah, I agree with the sentiment that it would be awesome, and we're willing to share all of our work with anybody, really.
Yeah, man. Matt, we're getting close to time. I wanted to circle this back to our baseball metaphor and ask you if you would answer the question, if you were sitting here as not the Babe Ruth that you are, um, but but maybe as somebody who's just new, been called up from the minor leagues, what would you, how would you tell people to hit a single around getting social determinants or social risk factors incorporated into their system and in their and then hopefully their payment?
I mean, I think the first step is to assess and kind of index what assets, what data, what is available to you, and maybe don't just look at sort of your usual suspects, and know what your gaps are. So if you have a really robust intake system as a provider, or if you're a payer and your enrollment data has some richness to it, kind of look at what that does bring to the table, and then where your gaps are. And I think just kind of one at a time, think through, you know, okay, we need some information on this. Where could we look at? And don't get bogged down on it being perfect. Good enough is good enough for the beginning. Engage your payers, and if you are in a state where your Medicaid is able to kind of have a little more of a centralized repository of that data like we have, and I know not that many states I think have something like that, but some do. Engage them. They're sort of, they're rowing to the same direction that we all want the same outcomes, and we're always looking for better ideas. So that's what I would say, is look at what you have. Don't assume that you don't have it. And if you don't, try to figure out where you can, and one at a time.
Great. Thanks. I'm going to ask one more call out if anybody else has any other questions. Otherwise, I'm going to turn it over to Rich and to Heather to close out, and just to talk about, remind everybody about the CME and the upcoming Care Coordination Academy. Rich, you unmuted.
Yeah,
so
we're happy to do that. So Matt, that was just masterful, and thank you for that. It would be really great if we could continue to learn from that. And I wanted to just give a quick summary to everybody on the SAG, because if there are echoes of what you are also hearing with our Academy sessions, that's very much by design. So the goal of today's discussion is not to turn the other 49 states and the associated territories into Minnesota. It's way too cold up there. But we want to learn from where they are on their journey. And we recognize and remember from the very beginning, when your respective teams applied to the Care Coordination Academy, our commitment is to meet you where you are. So I hope that you'll take away from the discussion today really the developmental trajectory, words chosen very intentionally, thinking about pediatrics, the developmental trajectory of Minnesota. What can we do, where, and when? We'll be bringing these things back into the academy. So with that, I want to just thank you, Matt. That was really, really wonderful. I would like very much to circle back to you, specifically talking about measures. Because we are lacking a national set of core measures that are relevant for children with medical complexity, and for that matter, even children or youth with special health care needs. So I will be asking to learn more from you and bring it to the Academy. So I'll hand it off now to Heather and to Thomas Charles, who I know is co-piloting with her today. And if you could wrap us up, but once again, Matt, that was spectacular. Thank you.
Yes, thank you, Matt, so much. Despite technical issues in the beginning, I think it all worked out really nice. I just learned a lot from you. Thank you so much. I hope we're able to stay in contact with you. I'm going to share the evaluation link in the chat now. And then as a reminder, our next event will be our broader large academy session that will get together on Wednesday, March 10th. We then have a SAG on Monday, March 22nd. If anyone has any questions or needs, feel free to reach out to me. I'm going to share this link now, and then in just a few by later tonight, I will send out the attendance sheet and then this evaluation link through email again tonight.
Right. Thank you, everyone. Thank you, Matt. Have a good rest of your day.